ready to perform a Deuk laser disc repair procedure on a patient who has 3 herniated discs in his lower back with back pain and leg pain. He's suffered for years. He's young, but he's been turned away from any treatment that works. Is he all right? We're going to make our incision. We've got our first needle in the L5-S1. I'll give him a little more numbing medicine on the skin. Yeah, I see that. So we were just talking, our patient has a very low tolerance for pain. Some people do have exceptionally low pain tolerance. Like, we're just giving him some skin numbing medicine right now, and you can see he's very uncomfortable just with anything. But we have to give numbing medicine. That's why we do it that way. We give skin numbing medicine. Our last patient, she didn't move at all during the entire surgery. But everybody's pain tolerance is different, so we have to be respectful of that and try to work with the patient. All right, we're going to go ahead and place the left L4-5 shot. I'm going to use the X-ray machine to do that. Right now we're a little bit higher than I want to be. Shot. So I'm looking at the disc of the L4-5, and Jordan's got it lined up pretty good. Lay still. Yep, shot. 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 All right, you can see that we're near the facet joint at L4-5. Shot. I'll give him a little more numbing medicine. Let's go with some more num-num. See if that helps. Giving our patient some numbing medicine. It's lidocaine, marcaine. Shot. All right. Shot. Shot. Now I could feel the facet joint of L4-5. You could see that we're right there. Shot. 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 One of the things the other doctors told this patient was, go lose weight. That'll get rid of your back pain. But the reality is that weight loss does not get rid of back pain. Yeah. Shot. All right. At this point, I'm ready for him to be, I guess, but he is kind of awake, but he's uncomfortable. AP? Yeah. I do have to place 3-4, actually, so let's wait. Let's just make sure these are close enough, and then we'll, that looks good. Yep. So, we've placed 2 needles on the left side. One of the problems here with this particular patient is that his spine is just so far forward. And on top of that, he has a very low pain tolerance. We're literally just injecting medicine under his skin, and he doesn't like it. He's not having it. All right. I don't believe that. You're talking to a neurosurgeon. We used to run propofol on patients all day long in the ICU. But they were intubated, so there's a difference. Shot? Why are we so far north? I guess that's okay. Yeah. All right. Lay still. Shot. So we're lining up the 3-4 disc quite nicely. Shot. 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 You're doing great. Just lay still. We're right up against the facet. I need to go around it, which I just did. Shot. And head right for that disc. Shot. Now this is the 3-4 herniation, and I feel good about that one. You can see the needle is maxed out.
Can we switch lines? Please, thank you.
All right. So we're in at 3-4. I'm not ready for that yet. I haven't placed 4-5 or 5-1. I'm gonna go ahead and finish these two. Shot. Shot. Now we're right next to the bad disc, the disc that's causing all of his pain. Shot. Shot. All right. I'm certain about two of these that are in the proper place. The third one at 5-1, I'm not 100% sure. We're going to find out though. Now, just for those of you who don't know, this patient has 3 herniated discs. Well, we're ready for him to wake up a little bit. He has a L3-4 that is herniated on his right side, this being the right side, and then L4-5 herniated on the left, and L5-S1 herniated on the left. Now he's been suffering with back pain and leg pain, primarily left leg pain, for years. And like I said, nobody would operate on him because, number one, they don't know what to do, but number two, he's a big guy and they told him to go lose weight. And basically it's just an excuse not to fix him because they don't know how to fix him. So we realized that his weight problem wasn't the cause of his back pain, but the weight problem was a result of the back pain. And when you can't exercise and you can't walk, you can't do anything because you're hurting all the time in your back and your leg, well, how are you going to be able to stay fit? You can't. Just lay still. So we're just waiting for him to wake up. Lay still. Don't move. Let me know when you have him more responsive. Let's shoot an AP while we're waiting. He's still snoring away. Yeah.
Okay. Hey. Hey, buddy.
Lay still.
Keep your head down, okay? Keep your head down, okay? You're just waking up. Hi.
Yeah. So at 5-1, I'm a little concerned about. We may not be able to get the discogram done on that one. 4-5. That's the biggest herniation is at 4-5. All right. Is he awake? We may not get a good discogram because his pain tolerance is so low. There he goes. How bad is that on a scale of 1 to 10?
How bad is that pain, my friend? How bad is that?
How bad is that on a scale of 1 to 10?
How bad?
All right, you can see the herniation is huge. Let's show the audience the herniation there in the back. You can see the tear. Jordan's going to show you the tear. That's the tear, the big black line in the annulus, and then the herniation's coming out and basically hitting his nerve root. So, did he give us a number? No. All right, yeah, we're not going to be able to get a good number from him. But let's take a look at the next one. Shot. Yeah, this is the one with a big central herniation. Again, you can see. How bad is that on a scale of 1 to 10? How bad is that? Again, not able to respond. But Jordan, show the audience. Let's go to the x-ray there, Henry.
Yep.
Show the audience the tear. It's a huge tear in the back of his disc. right there. Go up and down. Show them the up and down. It's a black line there. That shouldn't be there. And then the herniation, you can actually see the tip of it to the left. Go left. Yeah, there. That's part of the herniation. All right. And then 5-1, we're not going to... I'll do a little bit of dye just to see where we are, but I think we're lateral in the disc, and we're going to have to probably do a little finessing to get into 5-1. We're ready to put him to sleep. Shot. Shot. Yeah, he doesn't like that either. So the issue with him is he's not really helpful to us. Patients are supposed to lay still, they know that. But he's just not able to do that. So we're going to have to give him a little more sedation and keep him comfortable. He's not going to be an easy surgery. What? Large tears, but patient non-cooperative. 5-1, just just leave it, unable to do. All right. Shall I get started, doctor? Take your time. Shot. At this point, we're placing the guide wire. Again, he has a very low threshold for pain. On a scale of 1 to 10, his pain threshold is a 1. Like literally, Viking is a 10. He's a 1. That's just the way he's wired. Nothing to do with him. I mean, it has to do with some other stuff too. Like people, you know, can affect their pain threshold by taking certain medications or supplements, and that can make them more or less sensitive to pain. He's very sensitized to pain. His pain is real, but he's definitely very sensitive. So right now the anesthesiologist, Shot, is going to be trying to just get him asleep where he's comfortable and not moving around too much. We are going to have a little bit of movement. It's all reflexive. It's not conscious. It's just, imagine if you were sleeping and someone pinched your toe, you would probably pull your foot away, not even knowing you're doing it. That's called a reflex movement. So he is going to have some movements that are reflexive. We may see throughout the surgery, just in relation to his, you know, comfort level. All right. At this point, if you have questions, feel free to type them up throughout the surgery. You're watching a live stream of this patient's Deuk laser disc repair. Let's go ahead and show our audience why do herniated discs cause pain in the back and why do they cause leg pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
You see the tube? No? All right, welcome back. We're just placing our tube, Shot. and confirming its position in the
What was that?
that
Can I have another extractor, please?
shot.
Can I have an extractor?
All right.
An extractor.
So we're definitely in the disc, in the herniation, and we're at L4-5. Go ahead and come out. We're starting with the L4-5 disc. Once he gets kind of deeper and more even with his anesthesia, we'll try for the L5-S1. All right, hopefully the video explains why people get back pain from a herniated disc. It's more to do with inflammation within the tear they have in the back of the disc, called the annular tear, which is what our surgery cleans, is the annular tear. We don't do fusion with this surgery. We're just basically debriding the tear. There's the tear right there. Don't move. All right. We're going to get started removing pieces of herniation. Now this patient came here with his family member. There's a piece of herniation right there. And like I said, he's been suffering for many years. Unfortunately, no one able to help him or willing to help him. Just telling him to lose weight, which is very unrealistic when your back is hurting you every day and your leg is hurting you to the point, let me have a blue towel here, that you can't even move yourself around, totally incapacitated with pain. Basically a failure for his doctors to diagnose his pain, the cause of it, and treat it properly. That there is degenerating disc from chronic inflammation. You can see it. It's kind of a golden color and whitish and gold. That's scar tissue and calcium. All right, what question do we have from our audience?
We have a question from Facebook, but from AJ Taylor.
All right, Mr. Taylor from Facebook.
And they asked, do these lives get saved?
Do these lives get saved?
Yes.
Is that what the question?
Yes, do these lives get saved?
Do these live videos get saved?
I would assume so. It just says lives. So it could one or the other.
Let's answer both because you could interpret it two ways.
True.
So when you cure someone's chronic pain, you do save a life. And at the very least, you save their quality of life. But I feel you save their life too. There are, unfortunately, a lot of people who just give up on life. Oh, look at that herniation. They give up on life because they're in pain all the time and there's no way out. They don't see a way out. And they lose hope. And it's the worst thing in the world when I see somebody losing hope, because I know we can fix their problem. And they just need to find us at Deuk Spine. Unfortunately, most doctors cannot fix the problem. So most doctors tell people like this that they're going to be in pain the rest of their life. And it's all in their head. And that's the worst thing, because it's not really all in their head. It's really in their spine. Of course, the perception of pain is in your head, because that's where your brain interprets the pain signals as being bad. But that said, it's kind of a incorrect thing to say to patients, is that it's all in your head, because it's not. It's real. That would be like somebody sticking a sword through your body and you're bleeding and you're hurting, and someone tells you, a doctor tells you, hey, it's all in your head. That sword in your body sticking out through you is not real. It's just, you're just imagining it, but it is real. And the only reason why the doctors say that is because they don't understand what's causing these people's pain. So yes, the lives are saved. If you're talking about these live streams, are they saved? Yes. YouTube saves them. They're all on YouTube, but also they are saved here at our facility. We save all of our surgeries unless we're having a problem with the recording equipment. And we've been saving our surgeries for 10 years, broadcasting them and saving them here for the last 10 years. So I don't know if that's what you're asking. Can't get to 12. There we go.
Better?
Yeah. All right, next question.
No current questions.
All right, Henry, would you please show the audience how the Deuk laser disc repair actually works to debride the annular tear and remove the herniation?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
It can't just be done when we ask for it. All right, welcome back. You can see we're staring right at the herniation at L4-5. There's a little bit. I don't know if it's okay. Something's going on here. Just not able to suck it out that well. There we go. That's better. Long, long, long. We're going to give this patient a little more numbing medicine in their disc. That way it'll help them with some of their pain. So, no, Luis, that's the longest?
Yeah.
Oh,
Yeah.
it won't fit. I'm going to take the scope out. Scope off.
Oh, please, stand by, right? Thank you.
Is that stuff, that's 1/4%?
We're gonna need more marking, please.
Should we be doing more than 1/4%? Huh? That's 1/2%? Not the skin. This is the, is that 1/2 or 1/4%?
This is
Half.
Yeah.
And the other one for the skin is 1% or what? What about the marking?
the marking is for the disc round. It's 100%. Yeah.
All right. Let's get the scope on. There, we just gave him a little more numbing medicine on the disc. Hopefully that's going to make him more comfortable.
My concern is when you're actually the choke part,
Mhm.
maybe we can give a little extra right before you hammer.
But we just gave him in his discogram. Oh, you mean later on? Of course, yeah, I'd be happy to give more.
So, Cristo, then can I have 20 cc with marking?
All right, this is inside the herniation at L4-5 on the left. Henry, what did you say? Do we have another question or not?
Yes, actually.
Wow.
Yeah, literally just a few seconds ago from Flade392 on YouTube.
All right.
And their question is there a point where the disc is so deteriorated, fusion or artificial disc makes more sense?
Yeah, great question. So number one, is there a point where the disc is so degenerated, putting an artificial disc just makes more sense? Yeah, so first of all, artificial discs are not allowed to be put in when the disc is degenerated. I don't know if you're aware of that. They're contraindicated for use in degenerated discs. They're only allowed to be used when the disc is normal, except for a herniation. So mild degeneration, herniation. So automatically artificial disc won't work. As a matter of fact, Medicare won't even cover artificial discs for Medicare patients because they have degenerative discs. All right, so second of all, the Deuk laser disc repair works in all conditions. It doesn't matter if it's a degenerated disc, a herniated disc, or a bulging disc. It works for all of them. And it works better than any other surgery out there. There's nothing that works better, not even close. The reason is because it's not the degenerative disc that's the cause of the patient's symptoms, it's the annular tear. And the Deuk laser disc repair is the only surgery that works on the annular tear. Okay. Laser.
Okay, 0%
So if you watch the last surgery we did just before this, the patient is 90 years old. What's her age, guys? 90?
90.
Just over 90 years old. If you go back and look at the video, she has no disc left. It's gone. It's bone on bone. And yet her pain will be gone. Why? Because you don't need something in the disc space. That's the big lie, the big myth, the big misinformation that's been going on for many years by doctors telling patients, you've got bone on bone, you need a cage in there. It's basically what they tell them to sell them, a cage or an artificial disc. But it's nonsense. None of it's necessary. We do these laser surgeries, we don't put any cages, we don't put any artificial discs, and yet the patient's pain goes away 100% from their disc. Now if they have facet pain, we have to deal with that, but that's a different issue, nothing to do with the disc. My point is that we're not putting anything in the disc space. It's literally bone on bone in that 90-year-old we just did, and yet her symptoms will be gone. That's because the symptoms of back pain, leg pain don't come from bone on bone. They come from the annular tear. All right, Dr. Berndes, what do you think? Anything else you can give them that would make them a little more comfortable? What are your thoughts? You want to avoid ketamine? Yeah. So it's just a little fentanyl? Yeah, understood. So this is the herniation we saw in the MRI right here. I'm literally at the base of it, whittling away, trying to get rid of it a little bit at a time. And we're trying to keep our patient as comfortable as possible while we're doing this. It's not easy.
Oscar, go to the other side. Crystal, no. Oscar, go over there. Crystal, take care of the laser. Thank you.
So what do you guys think about wrist straps or something like? Huh? Oh, really?
You stand by, right? Laser. Stand by.
Lay still. You're doing great.
You're doing great, buddy. Try to keep your head still, all right? Your head still?
Yeah. He wants to make it challenging for me. All right, any other questions?
No current questions.
Now, do we do the video on how the laser works?
How the laser works and the back pain, yes.
All right. Let's show our audience what happens if you don't have laser. What other surgeries available, like a fusion, for example? What's the difference? Give them an idea of the difference between the two procedures. I need probably 5 more minutes on this disc.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place, and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, welcome back. It's been an interesting struggle. We're at L4-5. This is the biggest herniation by far. I've been whittling away at the base of it. Our patient is really difficult to control his anesthesia. He's not really cooperating. He's wiggling around and moving around, giving us a fit. But we're doing everything we can to get out as much as we can. I think it's going to be good. I think he's going to be happy with the results. But I would love to be able to do a little bit more. I just don't think I can. So we're going to wrap this disc up. We're going to go to L3-4. This is clearly a painful disc for him. And I feel good about it. This whole thing was a herniation here at the back of the disc. It whittled it down to very little left. There's just a little bit left here. How is he doing? Can I whittle a little more? Just another 30 seconds maybe? Yeah, I think he's going to feel so much better when he recovers. That looks good to me. That's where the herniation was sitting. Just a little ice, like the little cap of it's what's left. I'll go grab one more time with the grabber. See if I can pull anything else out. For these sort of midline-ish herniations, you've really got to reach across the midline. That's what I've been doing. You want to start as lateral as you can on the body, aim as medial as you can, and kind of slide along the back of the disc. It's all about getting the right trajectory. Lay still. Again, he's making it super challenging, not on purpose. All right, any questions from the audience?
No current questions.
So for those of you who watch these, you can see no two are the same. They're all a little different. And, you know, we boldly go where no man has gone before, or woman, trying to help people get out of pain. But it takes a Herculean effort, right, doctor? Not just on the team side, but on the, well, with the anesthesiologist as well as the surgeon and my assistants. All right, I think we've done probably a good 80% of this herniation is out. We're not going to get 100%, you never do. I think we've done everything we need to get that nerve decompressed. Just take one more look here. Little epidural fat, some epidural veins. I'm going to open them up here. That's a little posterior ligament. Take a look and make sure we've got everything we need out of there. We're literally sliding along the back of this disc. We're done here on this one. We're going to move on to, and the nerve root's going to be out there to the left. We're going to move on to the L5-S1. Scope off. We'll do a little antiseptic. Some irrigation. You're doing great. Lay still. Yeah. You're doing great. Lay still. We're going to take this tube out. And put a little pressure as we get the tube out. I'm going to stay here. Yeah. Tube's out. I'm just putting a little pressure on his paraspinous muscles. Switch out. So remember, when you do this, you're coming out of the paraspinous muscles. You're not cutting the muscle or anything. I'm going to go 5-1. You're basically spreading the muscle fibers. So any kind of tissue in the human body that has fibers are long strands. When you go through them with the dilator, you're not cutting them. So you're not cutting muscle fibers, you're not cutting annular fibers. You're literally spreading those apart. The only thing you're cutting is the skin. The fascia has fibers, the muscle has fibers, the annulus has fibers. So you're only cutting the skin to do the surgery. Nothing else is being cut. And because you're only cutting the skin, you're only going to get scar tissue at the skin. All right, we're going to go for L5-S1. It's going to be a reach, and it's not going to be easy.
Yeah, we have num-num.
We'll give a little num-num. Let's do some num-num. You're doing great. Yeah, hang in there. Give a little num-num. Let's have the, lay still. No. I need the guide wire. Okay, guide wire is going in. All right, let's get him comfortable as much as we can. Really? I guarantee you he's not going to be sensitive under the skin. I guarantee you that's not going to be the case. Huh? I'll show you. Shot. I think he's sensitive everywhere. I mean, when you have a low pain threshold, you're not just low at your skin, you're low at all the pain sensitive structures. So he's low at, yeah, skin, fascia. But the one that's going to bother him the most is the disc, the annulus. That's where the pain's coming from. It's inflamed. He has a tear that's so inflamed. All right, let's see where we are here. Shot. Let's try to clean up the picture as much as possible. I'm going to need all the help I can get. I think you're off on orbit by a degree. So let's see if you can improve the orbit. Well, I pushed down. I may have given you more than a degree. Shot? That's the wrong direction, I think. I could be wrong. Let's try the other way. Try some more. It's hard to tell. Shot? Yeah, we're going the wrong direction, I think. I think we've... Yep. Remember, if you do surgery like this that uses x-ray, that's pretty good. It's not great, but I don't know why it's not great. It may be all the omnipaque. Whenever you do surgery like this, folks, you've got to take into account the fact the patient's moving. Look. All right. Huh? Listen, if it was the skin, I'd be happy to do more. It's more the fascia. I may be able to do something on the fascia right here. Let's do some num-num on the fascia. So I'm literally bouncing against his fascia most likely. I got it. Move your hand. Oh, he's snoozing away. All right, so that should help a little bit. Let's see what we got. We still got a long way to go. But I'm on his fascia right now. Now I'm through the fascia. Let me give a little more num-num. So we just went through the fascia, and you can see he responded. As a neurosurgeon, you're taught what areas of your body have, I got it, have nerve fibers, pain fibers. You learn what those layers are. And you learn to numb them up. All right, shot. So we're making our way down to 5-1, left side. And again, I told you this is not going to be an easy one. So I'm going to need all the help I can get from my anesthesiologist. Shot. Here we are. Now he's going to start getting unhappy now that I'm down by his tear. Shot. Just passing his facets. Can feel a lot of scar tissue here. Okay. All right, let's take a look at an AP view just to see where our tip is. I've got it pressed up against the facet. Remember, I'm coming in just lateral. Give me a coker. I got it. Hold on, Jordan. Nice job on the anesthesia shot. All right. You can see the, yeah, let's try to get that a better picture. That's better. Yeah, so we're sneaking up on that disc. It's looking good so far. I do want to get a little more medial. Hey, lay still. Shot. It's not terrible. All right. I think I'm under the root. I'm going to take this out. Wait. I'm going to aim it a little bit more medial. Shot. Shot. Give me an AP. Take it. Just a quick AP. Yeah, he's not going to like this. Quick AP. Okay. His facet is literally pushing me lateral. Shot. 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 Let's get an AP. Take your time. Did you find the piece that fell? Let's do a discogram through the dilator. Let me have a guide wire first. Nice job on his anesthesia, doctor. Thank you for keeping him comfortable. Shot. Oh, you're giving me too much credit.
Your head down. You're doing great.
Lay still. Maybe we spoke too soon. Any questions from our audience?
No current questions.
I don't know.
Oh, never mind. We just got a question. And
Shot.
this comes from Omar on Facebook.
Hi, Omar. Shot.
And he asked, can anesthesiology do anything to
Shot.
limit his movement?
No. The anesthesiologist cannot. You can give a muscle relaxer or a paralytic, which will stop him from moving, but he would then stop breathing and he would die. So this is the most we can do. And this is what surgery looks like when you do sedation. So this is what it looks like. You guys just don't see it. So to you, it's strange and
Muscle relaxation.
scary.
Class anesthesia.
Huh?
Muscle relaxation. You use that. It's a whole different class of anesthesia.
Yeah. But to us, we see this all the time. We're used to dealing with it, shot. And we know that this is just how it is. There's not much we can do. Shot. So we've done everything we can do with the anesthesia, and there's nothing more that can be done. Let me just look at it. But this is part of anesthesia when you don't have a tube down. Shot? All right. So when we have a tube, it's called, I don't know how good it's going to be. I'm worried we're a little lateral. Fluoro out. When you have a tube down the patient's throat, it's general anesthesia. Then they don't move. That's when you see it in the movies, they're laying there still. That's easy anesthesia. We'd love for it to be that way. But we can't do the surgery like that. It has to be done with sedation. And when you do sedation anesthesia, they don't show you that in the movies because the patients would be moving around. So you guys are just not familiar with it. We are. But this is totally normal to have this kind of movement. Now, some people move more than others. We like it when they don't move much, but yeah, no, we're too lateral. Shot? We're just not going to be able to get into this disc.
1 second. Lights on, please. Lights on.
Yeah,
Thank you. Scope off. I got it.
unfortunately.
You want to do some,
Nope.
you know?
Sure. Yeah, 5-1 is a no-go. I've done everything I can, but it's just not seated properly.
All right, you're doing great.
And that has more to do with his body, his anatomy. Just being his spine is so forward. And he's got the facet joints that are pushing us lateral, so we can't get into that disc. All right, any questions from our audience?
Yeah. No current questions.
All right, I'm going to switch sides to go to the other side because we're going to do the 4-5-5-1 on the left and the 3-4 on the right. Now he's starting to get right leg symptoms, but his left leg was the biggest problem. Let's get the fluoro in. By the way, if you're watching these surgeries, you may see little things like this around. Do you guys see this? Henry?
Yes, yes.
Those are pieces of herniated disc. They just float out. When I use the laser, it breaks them up into smaller pieces and they float out and they kind of get all over the place. But we send the bigger pieces off to the pathologist and the smaller pieces just kind of laying around. We may try to collect them and send them off to the lab. How are we doing over there, guys? Doc? Is he doing okay? Yep. I'll give him some more numbing medicine. Mm-hmm. We'll do it.
I need probably more epi.
No, we're okay. All right, lay still. You can see that. This is literally, you go to the dentist, and the dentist injects your teeth with a needle. That's what we're doing, but we're not injecting his teeth, we're injecting his skin. So he has like 0 pain tolerance. I think I said he has a pain tolerance of 1. I think that's a mistake. He has 0. Yeah, I mean, what?
We already had some numbing medicine in there. We're bolstering it. You already had some.
Yeah.
You put it in when you first, right? So he's,
Yeah, I already gave him skin.
I know, that's why I was.
We're going to give him more numbing medicine in the disc itself. Shot. Let's see where we are. All right. Trying to get him more comfortable. He definitely doesn't like that. Anything to do with his discs, he's not happy about. Shot. All right. Huh?
I think you need to make a cut on this side.
I do. I really, he's right. I need an 11 blade. But this is not going in. I think this needs to be cleaned. So we're making our second incision. This is at L3-4 left side. Lay still. You have another guide wire there, Luis? All right. Pictures are blurry. It's just moving. Watch your fingers. It can't touch your finger. Okay, listen. When you open something like that, you have to angle it so that it doesn't slide towards your finger.
Do you need another set of tubes? Yes. Yeah. I'm gonna go grab it. You do it. Looks like it's a piece of bone flop.
You hiding down there?
I'm like this holding it. What do you need?
Yeah. We need to do a better job with restraints, Luis. We need a better job with restraints. I know, but you need to find a better arm restraint, surrender arm restraint system. Okay? I mean, most people it's fine, but when we're having staff wrestling, huh? The worst what? Is restraints. Right, but that's because he's wiggling around a lot. Yeah, but you know, we should have restraints that literally, you know, you can't succeed. It's metal, you know. Human muscle versus steel. Steel should always win. So there's clearly the fasteners are not adequate for his level of strength. All right. So everything's going good. We're just coming down on L3-4. Okay. I feel good about this one. This one is in great position for us to move forward. Shot. We've given more numbing medicine. Again, his size and his slight movements are really making it a little bit challenging. But that said, I think we're okay. Who's shot? Yeah. He said relax. Yeah, he's definitely challenging our team to the max. Shot? Shot? I don't want to take the dilator any further forward. So bring it back a little bit, about a centimeter or two. Shot? That's better. Shot? All right, let's see. Take it out. I think, ooh, it's a good thing we're done. Yeah, we're good. We're done. We don't need the mallet anymore. What's the name of that hammer? What's Thor's hammer's name?
Mjolnir.
That's it. Mjolnir?
Mjolnir, excuse me.
Mjolnir. All right. So Mjolnir has left us and is not happy that with my technique, perhaps, but we don't need Mjolnir anymore. Just like in the movie, we'll find Mjolnir later. All right. Okay, lay still. He's snoring away and he's still moving. So, yeah, he's completely asleep, yet his body moves. So, it's a reflex movement, folks. It's not that he's consciously aware. His body is just reflexively moving. Kind of like you move at night when you're sleeping. Your body moves, but you're not awake. You're asleep. So we do see those kind of movements from time to time. All right. I need a pedal, please. Ah. Huh? How you doing down there, Oscar? This disc? This disc is bad too, yeah. I mean, the disc is not as degenerated, it's more of a herniation, but you can see the blue? In a normal disc, you won't see blue. Let's put it to you that way. What you're seeing, the blue stuff, is not normal. Normal disc doesn't stain blue with our blue dye, the Deuk spine dye. Okay? The reason the blue Deuk spine dye stains blue is because it binds to what is called acidophilic or acidic tissue, specifically the nucleus pulposus that's degenerated. Normal nucleus is not degenerated, it's not acidic, it will not bind the blue dye. Degenerated disc, which is what we're after, will bind the blue dye. That's one of the reasons we use this dye, is to help identify the parts of the disc that need to be repaired or removed. And of course, you can't see this with normal surgery, open surgery. You need an endoscopic view. And that's what we have. So other spine surgeons don't even bother using the dye because they don't do endoscopic surgery. It reminds me, in neurosurgery, we now take brain tumors out using fluorescent dyes. And we use a machine called a microscope, similar to the endoscope. And the fluorescent dyes help us guide our resection, just like we're doing now. Except this is not a fluorescent dye, it's a vital dye, but not fluorescent. All right, what questions do we have from our audience?
No current questions.
They know everything. That's great.
Yeah.
So let's go ahead and run the video one more time on why the herniated disc cause back pain and leg pain. Those that missed it.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. So we are working on the left L3-4 disc. What I'm seeing is the disc is pretty badly damaged. All the blue stuff is abnormal. And it's kind of worse than I expected it to be based on the MRI. But things are going smoothly and we're almost done. This case has been particularly difficult from an anesthesia standpoint and also difficult from a surgery standpoint. The way his body habitus is, he's a big boy. His spine is very far forward, away from where we're operating. And so getting into the disc is very hard when the spine is anterior. You never know who's going to be anterior, who's going to be posterior, and whether or not you can reach it until you get the patient in the operating room. And unfortunately, we were not able to get L5-S1. I was able to get lateral in the disc, but it's too far lateral, and I'm not happy with that. So I was able to do a bit, but nothing really, not like I normally do. At L3-4 and L4-5, we're getting really good results. You can see that herniation right there. Very smooth surface. That's from chronic inflammation, smoothing out the surface. This blue stuff is all herniated disc. But look how collagenized it is here. Lots of collagen, lots of scarring. This is all scar tissue from his herniation, not from his surgery, from the actual herniation itself. It promotes an inflammatory response in the back of the disc, and that's where all of his pain comes from. People with a herniated disc, are we back, by the way?
Yeah, we're back.
Yeah, people with a herniated disc and an annular tear, they get inflammation. And that inflammation is the basis of their pain. Just like if you get a splinter in your finger, the splinter doesn't really hurt. It's the inflammation that hurts. It causes redness and swelling and tenderness. That's what we're dealing with here, is inflammation. People with herniated discs, they typically will have these episodes where the inflammation, spikes up for maybe a few weeks or a few months, and then it settles down again, and then it spikes up again and then settles down, and they get these cycles of inflammation. When they're feeling better and the pain's better, they kind of try to live a normal life, and eventually they start realizing certain types of activities are going to cause the pain to spike up, and then they start to avoid those activities. So it's behavioral modification. They're modifying their behavior to avoid the pain exacerbating. What they're really avoiding is a recrudescence of inflammation within the back of the disc. So the way that inflammation spikes up every time is really they're getting a fresh tear like a little more tear and more herniation coming out. And that new piece of herniation of disc sets off another inflammatory reaction, which then causes more pain. So they get a recurrence of their back pain, leg pain. And this is what we discovered at Deuk Spine Institute as the source of back pain from a herniated disc. Unfortunately, most doctors aren't aware of this, so they don't even know the source of back pain, let alone how to treat it. Now, pain management doctors understand the disc can be painful, and they do epidurals. Epidural steroids injections can give you a temporary improvement in your pain because they're treating the inflammation. But the problem is an epidural won't fix the source of the pain. Only surgery can. And since they're not surgeons, they're not going to fix your pain. They're just going to keep giving you shots. All right.
5 minutes?
Probably closer to 8 to 10. This disc is very fibrous. Let me see. Give me another minute or two. I'm looking right now. See that tear right there? Now this is interesting. Tears happen. There's the annulus right there. This tear happened right at the base of the annulus, right where it attaches to the end plate. You guys see the pink end plate at 9 o'clock, 8, 9 o'clock? That's bone. So this annulus attached to the bone, and the tear in this particular patient at this disc is between the annulus and the bone. And that's why this blue stuff is down here. It's not in the middle. It's down at the base. Every tear happens in a different location within the annulus. And you have to have a tear in order to get a herniation. This one just happens to be low down in the disc. See how we're right up against the bone right there on the left? And the tear is right here, literally right against the bone. So he sheared his annular fibers off the disc. I mean off the bone. He sheared them, literally ripped them right off. Must have been some kind of trauma when he was much younger. And he's not old, by the way. I can't tell you his age, but I think he's a teenager, right? Or is he just outside of being a teenager? Just a little older than a teenager.
I believe he said he did his deadlifting.
He what?
Deadlifting.
Deadlifting. So he was deadlifting. Folks, I've said this 1,000 times. Be careful in the gym. Don't deadlift. Don't do clean and jerk. Don't do hack squats. Those are the worst exercises for your discs. They will destroy your discs. And then you're going to have a lifetime of pain. Avoid those types of activities. Clean and jerk, deadlift, hack squat. Squats are okay on a rack as long as you're careful with good form.
We have a question.
Yes.
This comes from Trevor on YouTube.
5 minutes or less? Yes, Trevor.
And he asks, is there any reason to believe that kids are too young to have disc problems? My daughter is 18 and her doctor says they're too young to have disc issues.
Yeah, Trevor, one of the worst lies I ever heard doctors say is kids are too young to have disc problems. I've seen kids literally shocked me, a baby, a 1.5 years old with herniated disc. It can happen at any age. It can happen coming out of the womb. And believe it or not, they're painful. They hurt. I had a mother of a baby telling me she was watching her baby, a 1.5 years, and the baby was acting like it had back pain. A 1.5 years old, playing. And she got an MRI and sure enough had herniated disc. Now, of course, I would never do surgery on a 1.5-year-old, at least not in my lifetime, but at some point that baby is probably going to need surgery. I've operated on 15-year-olds. Like I had a skier, semi-pro skier, and she fell and hurt her back and had the same thing, an annular tear, bulging disc. Pain was coming from it. I fixed it. Pain went away 100%. So don't believe the doctors when they say kids can have herniated discs, bulging discs that are painful. They absolutely can. And this patient is literally just over his teenage years. I can't give you details, but from HIPAA, but yeah, we're just about done here. This is the end of the tear. The herniation is pretty much gone. I need about 1 minute and we're done. I can tell you this tear right here and this near teenager is a couple of years old. It's probably at least 3 years old, maybe 2 or 3 years old. I don't know when the injury was, but 2 years ago. I'm being told now, 2 years ago. So definitely consistent with that injury history. All right, so that should be it. Let's take a look. Nerve roots up there. That's all normal disc right there. You see how it's white? It doesn't stain. We're pretty much done with this one. But you can see it. There's so much, Trevor, there's so much misinformation in spine. That's why we do these broadcasts. I can't even begin to tell you all the false information, misinformation is incredible. But yeah, kids get herniated discs. They hurt, and they need it fixed. The youngest I've ever operated on was 15. And her pain went away right away after the surgery. She was very happy. It's sad that these kids are basically lied to by the doctors. And I don't think the doctors do it intentionally. I just think they don't know. It's kind of like believing in the boogeyman, People grow up believing in the boogeyman or believing things that just aren't true. Like these, I don't know, people that believe the earth is flat, right? I mean, they really believe it. As crazy as it is, they really believe it. And so there are these doctors that really believe that kids can't have this kind of back pain, that they're, I don't know, faking it, or these doctors convince themselves that there's no way the kids could really have back pain from a disc problem, okay? And the problem is there's not much known about discs. Discs are believed by everybody to be issues of adults. If you have a disc problem, you're usually an older adult. But kids can have disc problems, and they need to be fixed. Lay still, you're doing great. Don't move. All right, he's just waking up now. We're going to close up his incisions with a suture and a Band-Aid, and we're going to get him out of here into recovery, okay? This is our last surgery. If you have questions, feel free to type your questions up right now for me. I'll answer them for you in the broadcast room, okay? But yeah, surgery went as good as it could go. It was a real struggle here, but we got it done, and my team did a great job. Lay still. Yeah, he's going back to sleep. He's kind of up and down. All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's it. No nerve pain.
So the pain that you had before the surgery is
gone.
Gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. R. Deuk Majan with the Deuk Spine Institute, and I'm here with one of my patients who just had the Deuk laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Deuk Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that and nothing was really working. And then it eventually kind of got better, and then it would get worse and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video right here that we were pulling out lots of big fragments of disc herniation. You probably over your lifetime from 14 until now had at least 10, 20 different episodes of herniation, and that's what we saw when we were inside there.
Mm-hmm.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
Now, you're not from Florida.
No, I'm from Ohio.
So you traveled from Ohio to the Deuk Spine Institute in Florida. Why did you come all the way down to Florida?
There was nobody near us or anywhere near us that had any other option besides either getting a discectomy or a laminectomy or a fusion. There was just nobody was doing anything else. And I knew I didn't want to do that again because I'd already had that done. So it didn't work. And
Didn't work.
I had a really amazing physical therapist that connected me with you, and the rest is history.
Yeah, your physical therapist found us and was intrigued with the surgeries we're doing here
Yeah.
and sent you here.
Mm-hmm.
So what are you going to tell your physical therapist? I call him Dr. Salinas. What are you going to tell him when you...
Oh man, I mean, I've already told him. I texted him the minute I got back to our Airbnb. I said, I feel amazing, and I can't wait to tell all the rest of the patients in our Facebook group, like, this works. So
It does. The Deuk laser disc repair really does work. Well, is there anything else you want to say to your fans out there or friends?
my fans and my friends, thank you for praying. Thank you for believing me. I think that's one of the biggest things. There's a stigma around back pain because you can't see it, that people are just faking it, or maybe they're babies. Like, why can't you just deal with the pain? And it overwhelms you. And so to come someplace that believes me and then fixes the problem, and now I'm sitting here and I can be like a fully active mom. So I'm just beyond thankful. Thank you.
Yeah, chronic pain robs people of their dignity and their happiness and joy in life, and also their loved ones, the people that care about them.
Yeah.
Because they suffer with you.
Yeah.
Yeah.
A lot.
Well, congratulations and praise God.
Yes.
You found us.
Thank you very much.
And I think you're going to do fantastic.
I'm looking forward to being strong again.
Awesome. All right. I'm Dr. Deuk here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration, where I could maybe get up, stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. You can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I'll just, I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means, it's because I hurt so bad. I never experienced pain like that. And like I said, there's no
because you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
Just up a state or two, right?
That's right. Yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since
Yep.
we did your surgery. You went home an hour after the surgery, back to your hotel with your
Yep.
lovely family who I met.
Yep.
And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir.
Yeah.
Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have prettied you up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right, going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I am just going to rest and watch TV, but then we're going to get on a plane a little bit.
Awesome.
Yeah.
All right. Well, congratulations. You had faith.
Yes.
Took the
I have
leap
faith.
and you got the surgery done.
Yes, sir.
All right. Awesome.
Yep.
Okay. Just finished performing a Deuk laser disc repair lumbar for lower back pain, and both leg pain, but worse on the left. Our patient comes to us from Naples, Florida, or Fort Myers. I'm not sure. I may be getting it mixed up, but I think it's Naples, Florida. So now he's been suffering. He's young. He's not older. He's just out of his teens. I can't give you any more details than that because of the federal laws and HIPAA. But he's, been suffering with lower back pain for years. And I heard in the operating room from my team that he hurt his back while he was, I guess, he's a football player, and he hurt his back doing some heavy weightlifting with one of those techniques that I tell everybody, avoid this no matter what. I don't care if you're a pro football player. Don't do clean and jerk. Don't do deadlifts. Don't do bad form squats, and avoid hack squats if you can. It puts too much pressure on the discs and it can cause them to blow out. So he injured his lower back a couple of years ago. He's been living in pain, horrible pain. He's gone to the doctors down in Fort Myers or Naples, sorry, and the doctors have pretty much just blown him off and told him, there's nothing wrong with you. There's no way to fix your problem. You got to live with the pain. And you'll hear his story, I'm sure. We're going to do a testimonial on him, and we'll do that this week when we check him out. But he'll give you the story. I mean, it's very common. I hear it all the time. People in pain that are being told by doctors there's nothing wrong, we can't find anything, you got some bulging discs, that's it. Well, those bulging discs are the cause of the pain, and the doctors just don't know that, and they're misinforming the patients, they're misleading the patients. They're not doing it, I don't think, intentionally. I just don't think they know, and that's why we do these broadcasts, is to get the word out. All right, people got to know the truth. The truth is, back pain has a cause, it has a source. All right, there's a few things that cause back pain. As a matter of fact, there's 32 specific things that can cause back pain, 32, but some of them are a bit redundant. Okay, and let's review those 32 things that can cause back pain. By far, the number one cause of chronic back pain is this little guy right here. That white thing that looks like a hamburger between two buns, that is a disc, and specifically it is the L4-5 disc, and we fixed that today in this patient. The next most common cause of back pain is the L5-S1 disc, then the L3-4. Okay, so herniated disc, bulging disc, ruptured disc, it's the annular tear in the back, that's the cause. L4-5, L5-S1, L3-4 in that order. Okay, the next most common cause of back pain are these little doohickeys in the back of the spine. We call them facet joints. All right, I didn't make the name up, so don't blame me, but they're called facet joints. You got a left and a right, a left and a right, a left and a right, a left and a right. And of course, the most common to cause back pain are the L4-5 facet joints, left and right. You keeping track of how many we got now? So we got 1, 2, 3, 4, 5 causes of back pain with the discs, and then you got 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Then you can also have fractures, which are very rare, by the way. That's 16, 17, 18, 19, 20. Sacral fracture, 21. Inflammation of the sacroiliac joints, left and right, 23. You got piriformis muscles on the side, they get torn, 25. You got a coccyx down here, there's a ligament, that's 26. And then what am I missing? Infections and tumors. Well, that's all I can think of right now. So we're close to 30. Long story short, you can't get an MRI scan and that won't tell you what causes back pain. It is wrong by itself 98% of the time. You must have a competent, capable doctor examining your back, figuring out based on where their pain is localized to, what's going on in the MRI, making the right diagnosis. MRIs don't give you diagnoses necessarily, okay? It won't tell you where the back pain comes from. You got to have a doctor who knows what they're doing. All right, we have any questions?
Yes. This comes from...
Hi, Karen. Karen Foley's here.
This comes from Brian Johnson on YouTube.
Brian Johnson, hi there.
And he asked, what are the differences between pain from your disc versus pain from your facets?
So Brian asked, how do you tell the difference, or what are the differences between pain from the facets and pain from the disc? All right, so to a patient, you may not be able to tell the difference. That's why you need a doctor to sort of suss that out. And you know, when you ask the patient, what's wrong? I got back pain. Well, when is it? When I move. I got back pain when I move. It's in my lower back. That right there, you can't tell a difference between disc and facets, period. Now, if the pain is more to the side, the facet joints are off midline, they're off to the side. So on exam, the pain is off to the side, either right or left, or both, if they have facets on both sides. And when I mash on the skin above the facets, that will be sore. Now also with facet pain, typically it's worse with extension. So bringing your chest up and kind of tilting back, all right? And you might feel some popping and grinding with the pain. That's a good sign it's the facet joints. But the best test of all, the only definitive test, is to go in with a needle, and we do what's called a medial branch block. And basically, we go in with an x-ray machine and we numb up those facets with Novocaine, the ones we think are causing your pain. If we numb your facets up with Novocaine and it takes the pain away, it's the facet joints that are causing the pain, not the disc. So a diagnostic block is the most sensitive test to make the diagnosis of facet pain. Now let's assume for a moment the facets are ruled out by our diagnostic block. We've said, nope, we tested the facets, there's no facet pain. The only other thing there is a fracture or the disc. And if there's no fractures on the MRI, then you know it's not a fracture. So then it's the disc. And 80% of the time it's the disc anyway. You just know that based on percentages that I told you. That's based on our experience. So you just look on the MRI and see what kind of disc anomalies are going on in that area on the MRI. And that gives you your answer. Okay? So it's a process of elimination to figure out what causes pain, but you use a combination of statistical probability along with a process of elimination. And we do that here at Deuk Spine Institute. We do it better than anyone else. And that's why we're able to come up with the right diagnosis in almost every patient.
That is it.
That's our last question. Thanks for joining us today. We don't have any more surgeries. I think the young man will do very well with this surgery. I think he's going to be very satisfied with the results, and his relief will last him a lifetime. So I'm very excited for him. Aside from that, if you get a chance, join us. Are we operating next week or no?
I know we're not operating Thursday.
Tuesday.
Yeah, we just had to change plans, but we may actually be operating this week on Thursday. We have added on a patient with 3 herniated discs. I think it's L2, 3, L3, 4, L4, 5. And he's got back pain radiating down into his right leg. He's got atrophy of his quadricep muscle, his muscle shriveling up from the nerves getting pinched so bad. So, and he's actually a doctor. So we're going to be treating him this week, and we'll probably broadcast him on Thursday. We'll get more details. Check the calendar on the website. You can find out. Other than that, thank you for joining. Hope you enjoyed the surgery. It's always a pleasure talking to you. I'm Dr. Deuk Majan and Henry here, and today we have our visitor